Hi, everybody. My name is James Sulzer. I'm a rehabilitation engineering professor at the University of Texas at Austin. I run the Rewire lab, which is, here's a logo down here. We use robotics and engineering principles to answer questions in rehabilitation. I also started the CARE initiative and still run that at the University of Texas at Austin with my co-director, Linda Noble. We are a rehab research consortium that's very multidisciplinary, involving neurology, psychology, speech, kinesiology, all over the university and even beyond that. My research is funded by NIH and the NM4R. But the reason I'm talking to you today is not as much about my research, although I hope that contributes, but also my experience as a parent with a daughter who recently suffered a severe TBI. I hesitate there because it's been almost exactly a year, May 19th of last year, where she had a severe TBI. So I'm going to share some of the insights that were new to me. Some of you out there I know are much more experienced in this field and may already know some of these aspects, but hopefully it's useful to all of you. So let's start with talking about my research. When I was a PhD student, and I still continue this research line now, I was at the Rehabilitation Institute of Chicago, now known as the Shirley Ryan Ability Lab, and at Northwestern University. And my goal was to build an exoskeleton to help people with stroke, and specifically stiff knee gait after stroke. I made it very lightweight, and it was just to see if it would help at all. It did help improve knee flexion during the swing phase. But as I'm going to show you in this cartoon right here, what it did not do very well was improve gait symmetry. So I thought people wouldn't need to circumduct the hip to swing around the hip anymore as a result, because they're getting all the knee flexion they need to clear the foot. But instead, as you can see from this cartoon right here, which is based on real data, they're actually swinging along their leg more. In biomechanics, I've spent some years as a faculty member trying to show this. Biomechanics really can't explain this. It is a neurological issue that is affecting that. And we think specifically the increased reflex response of the quadriceps during that assistance is actually making things worse. So by trying to solve weakness, I'm making spasticity worse, I'm making abnormal coordination worse, which means that in the future, my plan is to develop assistive technology that accounts for this damaged neuromuscular system. I have other research going on. So in light of that gait research, one thing we can do is avoid that response, but we can also try and reduce it. So spasticity may be the result of overactive activity in the spinal cord, specifically a lack of presynaptic inhibition. And a way of restoring that inhibition is through being able to downregulate your monosynaptic reflexes. An example of that is your stretch reflex you go in for the doctor for, but you can also elicit it electrically using stimulation. And that's what this cartoon is showing, is what's called an H reflex, is an electrically induced monosynaptic reflex. And so we do that on the peripheral nerve of the quadriceps muscle, and then we can measure that, and people can view that as feedback, as biofeedback, to try and reduce it. And we don't know exactly what strategies they use. People report a whole lot of different things, but eventually within a few sessions, they can learn how to do it. We've tried it in a couple stroke patients. It seems to so far have some promising results. Now that's at the level of the spinal cord. We are also investigating neuroplasticity at the level of the cortex. And this is a figure from one of our papers looking at the finger individuation. And you can see how the patterns in the cortex of the fingers actually overlap quite a bit. There is a possibility of maladaptive neuroplasticity after stroke. And if we could guide neuroplasticity to just the right areas, maybe we could avoid that maladaptive neuroplasticity. So we could do that by using neurofeedback, which is measuring brain activity using functional magnetic resonance imaging, and in real time processing that signal and showing that feedback to people. And they can actually, our studies have shown they can actually manipulate their brain patterns associated with individual fingers to a degree. And our next question is really fundamental in science. Eventually we want to apply it clinically, but scientifically, does cortical remapping actually change behavior or eventually recovery? But first we want to see if it changes behavior. And that's a very critical question in the field of rehab, because we don't know if it's a result of the recovery or actually initiates recovery. So is it causal? Another line of research is quantifying therapy dosage. So specifically, we don't know if someone receives an hour of therapy, what's actually going on. So here we put wearable sensors on people and measured the amount of motion in their heart rate throughout their entire therapy experience longitudinally. We found the amount of motion correlates most with recovery as opposed to the number of steps, which has previously been reported by other studies. And ultimately, what it means is that if we can measure perhaps what correlates best with improved recovery, can we adapt our therapy regimens around those variables? So that's where I was going. That's where I have been going up until May 19th of last year, when this tree branch right here, this is our backyard, fell and hit my then 3-year-old daughter on the head. It was a week before her 4th birthday. We took her to Dell Children's Hospital, obviously the emergency room, of course, and they had to remove part of her skull to allow her brain to expand. She had a blown pupil and there was pressure on the brainstem, and she was hours from death. So it was a quite severe injury. You can see one of the lesions right here. It has been a very long road in recovery and very difficult experience, as you can imagine. She spent 2 weeks in a coma where she had a ventilator, of course, and drained for cerebral spinal fluid. After those 2 weeks, we took her off the most heavily sedating medications, and she spent 6 weeks in physiatry. That's the purgatory between ICU and inpatient. She was mostly not responsive to the environment. The clinicians described it as a vegetative state, even though that vegetative state is, I guess, not a politically correct term, but that's what they use. She developed a lot of tone in her limbs, and over this period, she also developed severe osteoporosis in both her femurs due to the high tone in her legs. When we realized that she wasn't really waking up per se, we moved her to the Kennedy Krieger Institute in Baltimore, which specializes in disorders of consciousness in children like her. She was in the process of waking up, so then she upgraded to minimally conscious by the end of her stay there. And you can see that, she's starting to move her right arm a little bit, moving her left leg a little bit, but she's in a chair now. She looks a little bit more active. We moved her back home in September. You can see here where she's in outpatient therapy. We managed to get simultaneous outpatient and home therapy, so we could get a really intensive week of therapy. Here we see she's using her alternative augmentative communication, her AAC device, where it's tracking her eye gaze. This has been a challenge for us because she has difficulty in controlling her eyes, also controlling her head, and eye gaze machines don't like that. We took her to an intensive bout of therapy for a few weeks. Fortunately, at the new Napa Center in Austin, which just opened a few months before, the only intensive day therapy program for kids in this region of the country. And it was just up the street from us. So that was great. Got a lot of intensive therapy. And now today, almost a year later, this is her very recently, she is moving her legs on her own. And this is the light gate she's using, showing a decent degree of control of foot placement with both legs. So she's made a lot of progress in that year, but it has been a year and she has a really long way to go. So it's going to be a long road going forward. Now, what I want to talk about for the rest of this is some of the lessons that I learned. Hopefully they're helpful to you as well. And then some of the areas that I think can be addressed in the future, some immediate clinical needs, but I hope somehow this helps move the conversation along during our brainstorming sessions. So the first one is a little purposely controversial sounding, where is research going backwards? So let's rethink this. The classic issue of heterogeneity in a population. And I dealt with stroke. We always complain about heterogeneity in stroke, but really the majority of strokes are an MCA stroke, and you're going to get damage to the internal capsule. They seem to be, of course, there's a lot of heterogeneity, but there seems to be some consistency in that. Whereas with TBI, it's definitely all over the place. And some are anoxic injuries. If you're dealing with pediatrics, a 4-year-old girl is going to be a lot different from an 8-year-old girl. It's going to be a lot different from a 16-year-old boy. So there's so much more variability in that population. But before I get into that, I did my research, I like to think the right way. I came up with a problem. How do we improve walking after stroke? I wanted to find the minimal assistance they would need. So I had my scientific question. I gathered experts from all over RIC, all these clinicians and biomechanists saying, here's my problem. How do you suggest I proceed? And they said to go to stiff knee gait after stroke because it's a common disability, but also it's relatively homogeneous compared to the rest of stroke. Okay. Then I went into literature and I looked at, well, what do they possibly need? And this is a function of knee torque over the gait cycle. And they're clearly deficient in the pre-swing area of knee torque. So based on this imaginary average person who does not exist, I developed a knee flexion actuator to help people that do exist. And that's where you may be sensing the backwardsness comes. What would I have designed? And I don't have an answer to this. What would I have designed if I started with the patient and then found the best solution for that individual? Would I have even had an exoskeleton at all? That's where research might be going backwards. But yet this is what is rewarded in grants, what's rewarded in papers is this approach, whereas the case studies are not very well regarded at all, and it's understandably to some degree. But how do we address a population, and this is a relatively heterogeneous population, if I'm looking at pediatric TBI, how do we address a population as heterogeneous as them and have a solution for some imaginary person that might work for everyone? I don't know. I don't have a good answer for that, but hopefully it's something we can discuss. Another lesson is that details are critical, which devil's in the details. You guys heard all those expressions, but I think it's even more important here. So we'll start with a case example. My daughter doesn't have a lot of function, so it's not like she's going to be able to adapt to the technology. The technology needs to adapt to her. So if there's one function or one factor of that device that doesn't work for her, that's a problem. It's going to be critical. So that's where the details come in. And in this sense, this is one of her favorite toys I made for her. I was so proud of this that I could make something for her that she liked. It gave me such a feel of satisfaction and agency over her recovery. But at the same time, I don't even use this anymore. So this is a program on MATLAB I made where I put a family member, this is her brother, on one side of the screen, and the other I leave blank. So it encourages her to press the yellow button. This is a commercial, I think, enabling devices, a rock switch. I Velcroed some physical blocks on there so she'd have an easier time grabbing and pushing on it. It turned out she only wanted to pull these things off. That was her main thing, which pulled off the whole switch and caused all sorts of havoc because she likes pulling. Starting MATLAB takes a very long time and can be very variable. And MATLAB can also be kind of buggy. So in the end, the setup time was relatively long. It wasn't very robust. You have $1,000-some computer in striking distance of a daughter who loves destroying things and takes great joy out of that. So yeah, this is not getting used very often as a result, even though it's one of her favorite toys. It's those details that matter. She is not going to adapt to the device. The third lesson is that experience informs design. And again, these are obvious statements, but how does this happen? What did I learn along these lines? Well, let's talk about experience in one way, some of the challenges that informed our design. So this schedule, let's just take time as one of many examples where her time is affected. This is her blurred out medications and care schedule. Yellow is all the medications she takes. Green is all the feeding. Blue is all the care, like taking her her G-tube or her bathing, etc. And this is a very militant schedule. You need to be pretty consistent. You can't really miss medications here. So you need to make sure you hit these goals, refill the medications, make sure everything's running, okay? So that's a baseline. That's in the background. Then we have her therapy schedule. And I should note that we recently acquired nurses a little over a month ago, but until then, we did not have that support. We also have speech language pathology students who help out in the evenings, just give her some therapeutic recreation, which is very nice. So it's all been extremely helpful. But even with all that, it's still at least a 2-adult job where, and this usually falls to my wife right now because I had to get back to work and teach, but she's constantly on the phone being advocate, reordering things, scheduling appointments. It is a never-ending job right now. So it is a huge burden on the caregivers. You can see the time of the patient. So my daughter is in therapy here. We need to drive her to therapy. We need to come back from therapy. She's pretty tired. So if we have a new device for her we want to use and it takes 10 minutes to set up, this is a pretty busy day. Now, keep in mind, we have our own schedules, our own self-care that we need to account for. And on top of that, we have to supplement her therapy with all these other therapies we want to do. For example, we don't do the standard in therapy. We need to do that at home. So whatever we do, we need to save time. This is a very important aspect that needs to be taken care of. One of many, but I'd say one of the primary ones is saving time. So how do we do that? How does that inform design? Well, let's go back to that example I gave. So we have my daughter playing this game, which is motivating and I'd say accessible. That's great. I was so proud of myself for making this, but we don't use it. So it's kind of wasted technology. It's useless. So then what do we do? Well, I actually had a freshman engineering design group. They did such an excellent job. I was so impressed with how they worked. They have a keyboard, and they made, for example, a 3-button keyboard game where you could do animals, chicken, pig, cow. You could do shapes. You could do colors. Just the things that cognitively we're training her on. So it matches her cognitively, meets her there. It meets her with vision, how it has a black background and increase the contrast. That's really important too. It also is relatively robust compared to before. I moved that laptop off the tray, and now it's on an ottoman where I can project to the TV. We do it because I'm actually casting. It's through a website. So now I can have it on a server. I could access it at the Children's Hospital in outpatient therapy. All I would need to take is the keyboard. So that's very mobile. And it's versatile. So it could be used in her standard, could be used on the ground. It can be used, in this case, in the standard, we're also multitasking, where we have to do the standard. We're doing her feed at the same time, so we're saving time there. The device itself addresses vision, addresses cognition, and addresses motor abilities. So it's doing a lot of things all at once. And so we're pretty happy with the way this is going. And with all this going for it, it's still not an ideal solution. It still needs a lot more development and care. One thing right here, we need a black background with that chicken. Simple as that. Obviously, that's an easy fix. We want to make this keyboard so that it can be vertical or horizontal. We want to do that as well. So there's all sorts of things that need to be taken care of. They're important details, but that's how experience influences our decisions. So I want to finish up here. General thoughts. I think that this isn't a summary of the presentation. These are just more thoughts to kickstart discussion. As a rehab roboticist, I had been thinking often of technology that substitutes and automates therapy. For kids, you're always going to have a therapist around. You're not leaving a kid alone with technology where they could get hurt. You always need to be supervised. So why make technologies that automate therapy rather than technologies that enhance a therapist's abilities? So that's just a philosophy that I'd like to incorporate into my research. I did not really have a full appreciation for how fundamental and important cognition, attention, memory, motivation are in therapy. If she is not paying attention or motivated, she is not doing it. And that's so, so important for achieving these tasks. I think that rehab engineers should experience, definitely I don't want anyone to experience what I have, but experience the way patients live at home, experience where that technology would be, see how they go through their daily activities. I'd like to start implementing that as well. And I think that technology, just like therapy, is best when it's done as integrated into their day, into their daily activities. For example, I walk my daughter from the bath to her bedroom, supporting her under her arms, doesn't take any equipment, but it's integrating that therapy into her daily activities. And I'll finish up by talking about immediate needs that we've noticed. She may be having seizures. We don't know. There is no good way of detecting seizures. Wearing an EEG cap for a day where we have to watch her like a hawk and take her out of her routine is not acceptable. It is, I think, a problem that is solvable, but is not being done clinically. She developed osteoporosis in just 2 months. That is insane. Even though we were religiously ranging her in her feet to stave off that exact issue. I don't know what to do about it. I don't know if we know enough about it, but I wish there was a solution for this where we could more aggressively address the possibility of osteoporosis at the bedside. A shunt, which takes her cerebrospinal fluid from her ventricles to her abdomen, can fail. If that fails, we need to take her to the emergency room. She needs neurosurgery. There should be a way of detecting if it fails. There is no current way of detecting other than seeing her symptoms occur, and they almost always fail. So these are immediate clinical needs. I'm sure there's more, but this is one I wanted to put down there. So that's it. For additional information, a lot of this stuff is not in the paper my wife and I wrote. I hope you can all have a chance to take a look at it. It more in detail describes what we went through and all the considerations. So that was published in April, so I guess a month ago now. And again, if you want to contact me, that's my email for you. All right. Thank you very much. And I will stop recording now.